prevalence of hearing loss per 100,000 infants compared to some of the legacy conditions that we've been screening for some of them for the last 5 decades. So the graph is showing you patients with PKU, maple syrup urine disease, congenital hypothyroidism, and cystic fibrosis. But by far and away, hearing loss, the prevalence of hearing loss dwarfs these other neonatal conditions. We screen for hearing loss at birth, and the formal name for that process of screening for hearing loss at birth is called the Early Hearing Detection and Intervention process, and we affectionately call it EDI. So if you hear people talking about EDI, they're talking about early hearing detection and intervention, or newborn hearing screening. And through this process, we expect to see about 1 to 3 infants per 1,000 who are deaf or hard of hearing. And only since 2002 in Minnesota did every birth hospital in Minnesota screen for hearing loss. Prior to that, there was no mandate, and hospitals could choose whether they would screen infants or not. The goal of EDI is called the 136 program. 136, have the infant screened by 1 month of age. 3, have that infant who has screened, if they screen positive, undergo a diagnostic evaluation to determine whether or not they have hearing loss. And then 6, that child should have some form of habilitation in place by 6 months of age. So 136. Newborn hearing screening is very different than blood spot screening. So blood spot newborn screening is done at the bedside where you obtain a blood spot, but then the spots are sent to a central location in the state for screening. Newborn hearing screening is performed in the hospital at the bedside. And the thing that made newborn hearing screening possible was the development of automated tools. And there's 2 tools that we use. One is called the otoacoustic admission, or OAE, and that basically takes advantage of the fact if you sing to the cochlea will sing back to you. So you'll introduce sound to the cochlea, and then there's a little detector that then picks up the sound that the cochlea brings back. The other device is the ABR, or the automated brainstem response. And what this device does is that sound is introduced into the ear, but then electrodes are placed on the baby's scalp, and you're actually looking at the brain waves, the response of the brain to the sound. So you're not only assessing cochlear hearing, but you're also assessing central hearing. Both of these tools need minimal training of staff. One of the big concerns for barriers for newborn screening was that initially it was thought that we'd have to have an army of audiologists to go out there and screen babies for hearing loss. And with these tools, you could train staff that may not even have a professional degree to go in and screen. The cost is pretty low. It's about $10 to $25 per infant who is screened, and for every detected infant, the cost is about $7,000. Now, in the United States, we are pretty good at screening. Yes? So I can't tell you exact numbers, Cliff. So Cliff asked how does OAE and ABR compare in sensitivity and specificity. So there's a much higher false positive rate with OAE compared to ABR, but I can't give you exact numbers. So we're pretty good at screening. So looking at this graph, this is from the CDC and published earlier in the last month. And the blue lines represent all the babies screened, with the exception of those that have passed away or parents that have refused screening. And you can see in 2010, with 52 states and territories reporting, that 98% of babies who were born were screened. However, we're really good at screening. We're not really good at following up screening. So looking at this pie chart and focusing on the blue parts of the pie chart, so of the 3.88 million babies that were born in 2010, 58,000 babies did not pass their newborn hearing screen. The technical term for do not pass is refer. We try not to use the word fail, and that's another long discussion, but these are babies who were referred on newborn screening. Of that, about half the babies were accounted for, with 43.9% of all the babies screened being determined to be hearing at the end of a diagnostic process, whereas 8.5% were found to have hearing loss. So essentially 1 in 20 babies who do not pass newborn hearing screening will 1 in 5 babies who do not pass newborn hearing screening will truly be deaf or hard of hearing. On this side of the graph, there's about 8% here that at the time the states had a report were either in process, babies who passed away, or the parents declined screening, or patients that they just couldn't follow up for various reasons. But then when you look at this large red area, about 40% of the babies who refer or fail or do not pass newborn hearing screening are not followed up. There's nothing done after they're screened. And those children, typically, if they are deaf or hard of hearing, and we know 1 in 5 in that group will be, they're not picked up till later on in life. One of the things we know, and we've known now for a long time, with this landmark paper in 1998 and multiple follow-up papers since, is that screening babies for hearing loss and detecting them and intervening by 6 months of age is evidence-based. And what Christina Yoshinaga Itano did in Colorado was she took 2 groups of infants. She took a group of infants who were diagnosed with hearing loss by 6 months of age and a group of infants who were diagnosed at the typical time, which at that point was about 2 years of age. She habilitated both groups by placing hearing aids on them and provided them with a rich language intervention. And what she found at the end of a period of time was that the infants who were diagnosed before 6 months of age had hearing scores on par with their hearing peers and language scores on par with their hearing peers versus the infants who were late diagnosed who never caught up with their hearing peers. So what she says in her results, children with hearing loss who are identified by 6 months of age demonstrate significantly better language scores than infants identified after 6 months of age. And so this provided the evidence and the energy to move newborn hearing screening forward. Now, deafness is not one size fits all like everything else. There's different gradations. And so when we look at deafness, the main type that we see in children is sensory neural deafness with severities mild, moderate, severe, and profound, with mild, moderate being primarily in the speech range, with severe to profound being greater than that. But if you look at most of our speech on the audiogram, that just to orient you to the audiogram, as you move in this direction, frequency increases. As you move downward in this direction, loudness increases. And what you can see is most of our speech sounds are occurring here in this range at between 20 and 50 decibels, with sounds like F and S and TH, these really high frequency sounds, being really very soft. And so children who even have mild, moderate hearing loss will miss these sounds. And evidence shows that even children with this degree of hearing loss have a much greater risk of repeating grades in early childhood years. So it's really significant. The other thing I want you to take from this is that even a child who is considered severely deaf can hear things like this dog barking, the piano playing, or a chainsaw. The American Academy of Pediatrics has handouts, and I don't know if you guys have pulled these off the AAP website, but they're very helpful for medical home providers who care for kids who are deaf or hard of hearing or fail the newborn hearing screen. And so if a child is screened at birth, if they fail the screen or the screen doesn't occur, they are rescreened as an outpatient. Then if they fail again, are referred to audiology. And there's a whole number of referrals that need to be made, including referral to Part C, which is the school district intervention, and then referral to specialists like ophthalmology, ENT, and genetics. Now, if a child passes newborn hearing screening, it doesn't mean they're permanently off the hook. They're never going to be deaf or hard of hearing. So if a parent raises concerns, or you have concerns that a child may be deaf or hard of hearing, even if they've passed newborn screening, we're still responsible for going back and reevaluating that child to determine if they can hear. So deafness, as I mentioned, is a a group of conditions that are caused by different things, with the majority of deafness being caused by genetic causes. But I want to focus a minute on environmental and idiopathic causes. In the environmental group, the most common cause of hearing loss in children is cytomegalovirus. And Mark Schleiss and I have worked on some projects to understand this a little further. And Mark has done a tremendous amount of work on this area. But in the genetic group, there are two main groups. There's syndromic and non-syndromic. And in the days before we could look at genetic testing in kids, our job as providers, when we saw kids who were deaf, was to try to figure out which kids have a syndromic form of hearing loss and which kids have a non-syndromic form of hearing loss. So the syndromic group are kids who have other conditions that associate with hearing loss. And there's over 400 different syndromes. And I know you all have lots of time today, so we're going to talk about each of the 400 syndromes and discuss them in detail. We're not. We're going to talk about a few. But I just want to highlight a couple here, particularly Usher syndrome, which is retinitis pigmentosa and hearing loss, branchiotorenal syndrome. A number of you have cared for kids who have branchiotorenal syndrome who spend a lot of time with us. And this is a condition where kids have ear malformations, renal malformations that could lead to end-stage renal disease and hearing loss. Jervell-Lang-Nelson, which is long QT and hearing loss. And that's really important. And it's the reason why all kids who come to the Lions Clinic get an EKG when they walk in the door, because we don't want to miss somebody with long QT. It's about 1% of kids who are deaf or hard of hearing. And then finally, enlarged vestibular aqueduct and Pendred syndrome. Pendred syndrome is the association of thyroid goiter and hearing loss. So the non-syndromic group, and this is the largest group, the majority of kids with non-syndromic hearing loss, meaning they have no other conditions but the hearing loss, is autosomal recessive. And there are about 40 genes that have been identified in this group, with the most common being GJB2 and GJB6 as a cause of hearing loss. About 15 to 24% are autosomal dominant, 1 to 2% are X-linked, and then there's a handful of mitochondrial loci that are associated with hearing loss. So because of this, a number of groups have endorsed including genetics evaluation in the care of children who are deaf or hard of hearing, and this includes the Joint Committee on Infant Hearing, the American Academy of Pediatrics, and the American College of Medical Genetics. So changes in GJB2 and GJB6 are the most common cause of hearing loss worldwide. GJB2 and GJB6, GJB, gap junction beta, so gap junction beta 2 and gap junction beta 6 are the genes that encode the proteins connexin 26 and connexin 30. And this is one of those unfortunate circumstances where the gene and the protein have a different name. So when you talk to families, many of them have heard of connexin but may not have heard of GJB2, especially when you're sending genetic testing out. And most people will call it the connection test rather than the connexin test. So I mentioned that they're the most common cause worldwide, and in some populations, particularly in Europe, if you screen a group of deaf or hard of hearing individuals, you will find genetic changes about half the time. So one of the first studies performed in the United States was performed in Iowa at Richard Smith's lab and published in JAMA. And what they did is they looked at 52 probands who were deaf, and they found that 42% of those probands had 2 mutations in GJB2. And what they found was that the majority of the genetic variants they found, 29 out of over 43 variants, was that there was a single deletion of a guanine nucleotide at position 35 in the gene. So 35 del G was the most common allele. And this suggested that this might be a very good tool if you were going to use genetic testing as a screen for hearing loss. One of the nice things about the GJB2 gene is it's really small. And you know, if you want to say something nice to a geneticist, wish to them that all the genes they study are small, because this is really easy to sequence. One sequencing reaction in both directions gets the job done. And so this is a small gene. It has 2 exons. The start codon is in the second exon. And it encodes this 4-pass membrane spanning protein that interacts with 6 other proteins of the same gap junction gene or related gap junction genes, like GJB6, and forms a hemichannel on a cell that can then dock with a hemichannel on the adjacent cell and allow transport of small molecules between the cells. GJB2 is expressed, or connexin 26 is expressed throughout the cochlea in a number of cell types. Interestingly, it's not in the hair cells, which is the hearing apparatus, the main hearing apparatus in the cochlea, but it's expressed in the cells surrounding the hair cells. And in mouse models that don't express connexin 26, the hair cells actually die. It's thought that one of the roles of this gap junction protein is to allow recycling of potassium. And if you remember, endolymph, which surrounds the hair cells in the cochlea, is actually a high potassium fluid. Now, this is a recessive condition, and if you remember, just to kind of review genetics, for a recessive condition, you need mutations in both copies of the gene to have a phenotype. So it's not like, like some you might have heard at one point, big D, little, little d, it's going to be dominant over the little recessive. You just need mutations in both copies of the gene to have a phenotype. So for someone that's deaf or hard of hearing, and we perform genetic testing, if we find 2 mutations, then we could feel like, oh, we know what this is. This patient has connexin 26 related hearing loss. But sometimes we'll test somebody and we'll just find 1 mutation. And the question is, are they a carrier? And we know from studies about 4 to 5% of Minnesotans are carriers of mutations in connexin 26. But in groups of individuals who are deaf or hard of hearing, about 11% of the time will identify a carrier. So that suggests that maybe there's something else going on. Maybe having that 1 mutation and something else may help find the cause of hearing loss in that child. To date, there's been over 100 different mutations identified in GJB2, and they can fall into 2 main groups. There's truncating variants. So a truncating variant is a variant that leads to a premature stop codon, and so you have no protein produced or very small non-functional protein produced. Or a missense variant that is an amino acid substitution that would lead to an abnormal protein that may function improperly or localize improperly. Some of the common variants that we see, the truncating variants include 35 del G, 167 del T, 235 del C. So they're deletions, they lead to a frame shift and little or no protein. And then there's a group of missense variants that could occur anywhere in the protein, but I want to highlight 2 of them on this table. Here's V37I, which is really common in the Asian population and occurs in this second pass of the protein, and then R143W, which is common in Africa. And so, as I alluded to, the carrier frequency for these alleles is pretty high, with 35 del G occurring in 2 to 4% of individuals of European heritage. And so that's as high as cystic fibrosis. 167 del T is identified in 4 to 7% of individuals of Ashkenazi Jewish heritage. 235 del C is found in about 2% of East Asian heritage, and V37I, which is a missense variant that leads to a fairly mild form of hearing loss, is found in up to 10% of individuals of East Asian heritage. And these studies have been replicated in China, South Korea, and Southeast Asia, as well as Japan and Taiwan. That's a really good question. So Bryce just asked if there's some sort of heterozygote advantage that maintains it. And people have looked at this, but I just haven't seen anything. I mean, there's talk of possibly better resistance to infectious disease, but I haven't seen a lot of replication. So one of the things people noticed that there were a number of individuals who were deaf or hard of hearing, had a single mutation in GJB2, and they began to look for other genes that may interact with GJB2 that can lead to deafness. And it led a group in Israel and a group in Spain to look at GJB6. And GJB6 is a protein that lives next to GJB2 on chromosome 13. And what they found was that there were a number of individuals who had this large deletion in GJB6, so that this is an example of digenic inheritance, where an individual could have a mutation in GJB2 and then GJB6 and be deaf. So over the years, we've gotten a really good idea what the phenotype is that's associated with GJB2 and GJB6 related hearing loss. And we know that individuals have sensory nodal deafness or they're hard of hearing. Hearing loss is typically bilateral, although there's some reports of unilateral. It's generally non-progressive, but there are some reports now that are coming out that shows a very slow progression over time. And that if you look at the temporal bone in individuals by CT or MRI, they have normal temporal bone morphology. And then we can make some really good genotype-phenotype correlations, where individuals who have truncating variants will be deaf, severely or profoundly deaf, whereas individuals who have missense variants will just be hard of hearing, will have a milder form of hearing loss. And these individuals have no extra auditory findings, so that if we identify this form of hearing loss, we don't need to go on a diagnostic odyssey looking for other health implications associated with hearing loss in those children that we identify 2 mutations in GJB2 and GJB6. So all this is great, and one of the things that we started looking at a few years back and were able to obtain funding from the March of Dimes to look at was the possibility of using newborn screening blood spots to screen for mutations in GJB2, and then also look at cytomegalovirus. So Mark Schleiss's lab and I got together, and we published 2 papers. This one was from 2009 in the Peds Infectious Disease Journal, where we looked at a number of spots for the prevalence of cytomegalovirus that could be detected by PCR. And what we found is about 2.7% of the spots from babies who didn't pass newborn hearing screening had cytomegalovirus. And that was very significant because when we looked at a control group of spots, only about 0.4% had cytomegalovirus. And that was surprising because it was thought that cytomegalovirus-related hearing loss might not be detectable by newborn hearing screening at birth. The other thing we looked at was the prevalence of GJB2 mutations. We looked at common alleles as well as sequencing the entire gene in a select subset of patients. And we looked at about 1,200 spots in a group from infants who failed newborn hearing screening and control spots from infants who passed. Sorry about that. And what we found was about 1 in 50 spots had biallelic mutations or 2 mutations in GJB2, suggesting a pretty high prevalence of this form of hearing loss among spots from babies who just refer. So these are from spots that we don't know the final outcome of the child. We just know if they passed or referred newborn hearing screening. So that's quite prevalent. We actually found 1 spot in the control group who passed who also had 2 mutations in GJB2. So this research was really exciting, but we can't do this anymore. As you know, political and legislative decisions have intervened, and newborn screening blood spots in Minnesota are now destroyed 71 days after babies are born. So this type of work can't continue, although it would be exciting, and I think it would be really helpful as a second-tier test for bedside newborn screening. So I promised to talk about syndromes, and I'm going to talk about 3 syndromes that are really common in hearing loss. So the first one is, this is a picture of a lady with a goiter. So this is Pendred syndrome. This is a retina with pigmentary changes and on the periphery, and then you could also see attenuation of the retinal vessels. And this is a retina from somebody with Usher syndrome. And this is an EKG showing prolongation of the QT interval. And this is Jervell-Lang-Nelson syndrome. So Pendred syndrome, the literature talks about severe to profound congenital sensory neural hearing loss, but in clinical practice we've seen everything, including mild hearing loss. This type of hearing loss is typically progressive, so that if a child starts out mild moderate, they generally will progress over time. Individuals with this form of hearing loss will develop a goiter. And the typical time is early adulthood, although we've seen children as young as 5 in the Lions Clinic with goiter. And these individuals have enlargement of the vestibular aqueduct, which is a common temporal bone abnormality. And I'll show you some pictures in a minute. The incidence in the general population is about 1 in 75,000, but 7% of kids who are deaf or hard of hearing will have mutations in this gene and have this condition. So it's an autosomal recessive and caused by mutations in SLC26A4. So what's enlargement of the vestibular aqueduct? So this is a bony structure that extends from the inner ear to the dura, and this is just a drawing from the NIH showing the endolymphatic sac, endolymphatic duct that's coursing through the vestibular aqueduct. And this is what it would look like if it was enlarged. Our patients don't come with nice drawings, which is kind of a drag, so we've got to scan them, and we could use CT and MRI. We've been using CT, and we're starting to talk about that a little more in light of the recent literature from Great Britain. But on CT scan, this would be a normal vestibular aqueduct. Here's 2 enlarged vestibular aqueducts. Here and here, they're kind of enlarged and dysplastic looking. And then finally, this is a very enlarged vestibular aqueduct. They typically don't occur in isolation, and it's not uncommon to see malformations of the cochlea in kids who have enlargement of the vestibular aqueduct. And so the malformation we see most frequently is what's called a Mondini deformity, where the cochlea, rather than having 2.5 turns, is missing the apical turn. So this is a CT. Here's the bottom turn of the cochlea, and here's the apical turn. I don't have a normal to show you, but normally when you look at a cochlea on a CT scan, it should look like a little cake, and it's a wedding cake, and it has 3 layers. But you lose the top layers, or they kind of smush together, and you end up with this abnormality here. And then here's a large, enlarged vestibular aqueduct. So why does this matter? This is the most common bony malformation in kids who are deaf or hard of hearing. And in our clinic and in a recent study from the East Coast, it can be found in up to 20% of kids who are deaf or hard of hearing. It's more common in girls. It's more common in both ears. And its presence is really highly predictive of progression in hearing loss. So for parents of a child who has, say, mild, moderate, or moderate severe hearing loss, and they want to know if their child's hearing will change over time or progress, the presence of enlargement of the vestibular aqueduct is very predictive of progression. So the gene, when we see enlarged vestibular aqueduct in a child with no other malformations, and there are some other syndromes that are associated with enlargement of the vestibular aqueduct, but the thing we see most commonly are changes in the gene SLC26A4. And this gene encodes a protein called pendrin for pendrin syndrome. And so the role of SLC26A4 is to transport chloride and bicarbonate across the cell membrane. And in 90% of the kids who have goiter, who have hearing loss and enlargement of the vestibular aqueduct, we will identify 2 mutations in this gene. So Usher syndrome. In the general population, this is a pretty rare condition, 4 per 100,000 individuals. But in the deaf and hard of hearing population, it's about 4 to 10%, so quite prevalent. And this is the most common cause of being deaf-blind. And this is a recessive condition. There are 3 types of Usher syndrome. Type 1 is severe to profound sensory neural hearing loss present at birth. Children will have vestibular anomalies and will have significant balance issues. And typically, vision loss occurs sometime during the first decade. We just had a patient that was picked up by ophthalmology actually at 6 months of age. So with a good ophthalmologist who's very careful and experienced, they could see subtle retinal changes before the visual changes are detected later on. One of the earlier signs of visual changes, especially in a child, would be suddenly a child's being afraid of the dark. The other thing we see in these kids because of the balance issues is they have delayed walking. So be really cognizant of the fact that if you have a child in your practice who's deaf or who's quite deaf, who's 2 years old and not quite walking yet, because typically deaf children walk on time, you should consider this as a diagnostic possibility for that child. Type 2 Usher syndrome has less severe hearing loss. It tends to be in the moderate severe range. These kids typically don't develop vision problems till later on, and the majority of kids that I care for have presented because they're teenagers and they go to the Department of Motor Vehicles, and the Department of Motor Vehicles screens their vision, so they check peripheral vision. Everybody's gotten the peripheral vision test. A lot of times those kids will not pass that test to be safe drivers, and they'll get referred for evaluation, and we've identified Usher syndrome that way. And then type 3 Usher syndrome has variable hearing loss, variable onset of vision loss, and is not as common in our population. Usher syndrome is a genetic morass, so there's multiple loci in the genome that cause Usher syndrome, so testing becomes quite complicated that hopefully will be relieved by the advent of tools like next-generation sequencing, where you could sequence a bunch of genes at once at low cost. We're not quite there yet, but we're close. But Usher syndrome type 1, the two most common genes are MYO7A and CDH23, accounting for about 2/3 of the patients. There are 3 genes associated with Usher's type 2. As you can see from adding up the numbers, no more research needs to occur because we don't know all the genes for USH2. And then Usher type 3 is universally caused by mutations in Clarin. Draveling-Nelson syndrome. So 1 in 250,000 individuals, so pretty rare. But when you start looking at groups of deaf children, about 1% of kids who are deaf or hard of hearing will have this condition. It's an autosomal recessive condition, but keep in mind parents who are carriers can have Romano-Ward syndrome where they're not deaf, but they could have long QT. And it's caused by mutations in 2 genes that are potassium channels, KVLQT1 and KCNE1. The typical phenotype is severe to profound sensory neural hearing loss present at birth, prolongation of the QT, and sometimes the first presentation of this condition is syncope. And I have colleagues who tell stories of individuals who, under stressful situations, like there's a story of a deaf student who was valedictorian of her high school class, just the stress of giving the valedictorian speech caused a syncopal episode. And of course, knowing if an individual has this condition before they have their syncopal episode, you could refer them to cardiology for interventions that could prevent sudden death. And that's why we screen kids who are deaf or hard of hearing with EKGs. So now we have some case studies. All right, so the first one. This is a baby girl who was born at Hennepin and referred on newborn hearing screening. And they did a fabulous job. She cruised through the system by 1 month of age. The family had diagnostic testing. They knew she was deaf. She was fitted with hearing aids by 2 months of age. A CT scan was performed, and she had normal temporal bone morphology. And the parents were of European heritage, and there was no family history of hearing loss. Anybody want to take a stab at the end of the story? Cliff? Yeah, so it was. So this child had 2 mutations in GJB2 and GJB6. The mutation testing revealed 167 del T and 35 del G. And so the healthcare implications for this child was really straightforward. We didn't need to worry about other conditions associated with hearing loss. And for a 2-year follow-up period, her hearing loss was really stable. All right, this is the second case, and this was a child who was born out of state who had fluctuating sensory neural hearing loss. He failed newborn hearing screening, had hearing aids placed, but had problems due to the fluctuations and then increasing severity over time. And testing for mutations in GJB2 and GJB6 were performed and were not diagnostic. And there was no family history of hearing loss, and we performed a CT when the child moved to Minnesota. So everybody's got their thought. So the CT showed bilateral enlargement of the vestibular aqueduct, and genetic testing for SLC26A4 revealed 2 mutations And so we were able to make the diagnosis of Pendred syndrome in this child. This child was young, did not have any thyroid disease, so his medical management plan was for the primary care provider to perform thyroid function testing on an annual basis. And this child actually developed quite severe to profound sensory neural hearing loss, where cochlear implants became necessary for him to be an oral communicator. The third case is a 5-year-old with profound sensory neural hearing loss. This child had no sign or oral language, walked at 2 years of age. This child had a sibling who was also deaf, and this child began complaining of night blindness, and the sibling also walked at age 2. A CT scan was performed and was found to be normal. Genetic testing for mutations in MYO7A, looking for Usher type 1, identified 2 mutations. And so the ongoing healthcare issues for this child was that it really became important to become cognizant of the fact that this child was going to lose vision over time, and what was the best language habilitation choice for this child, especially if they're a sign communicator and and they would lose their vision over time to the point where they would lose that ability to communicate. And then the hope is that therapies may become available for retinitis pigmentosa, as that area is moving quite quickly. So this is the last one. This is a 5-month-old with profound sensory neural hearing loss who was identified by newborn screening. This child had hearing aids placed by 2 months of age, but had little response to the hearing aids, and there were no temporal bone malformations by CT or ear malformations. This child's mother responded that he responded to a very loud alarm at close range, and then ultimately the family chose to use a cochlear implant for habilitation. CMV was sought after in this child and not identified. Mutations in GJB2 and GJB6 were also negative. So the cause of hearing loss in this child is unknown. But what we know from empiric observation, that in a family who has a child with hearing loss of an unknown cause, about 14% of the time they will have a second child who's affected, suggesting a strong genetic component. And so this child needs ongoing medical management. And really, for all kids who are deaf or hard of hearing, regardless of whether we know the cause or not, they need ongoing vision screening. So this child was referred to ophthalmology, and then also for follow-up for normal developmental milestones. So thanks for paying attention. Thanks for being here today. I also want to thank my division and my division chief, Zuberi, for allowing me to participate in this very translational part of my research. I want to thank the AP for funding to allow us to travel around the state and give grand rounds on hearing loss. I also want to thank Kirsten Coverstone and Nicole Brown from the Minnesota Department of Health. They've been tremendous partners. They also lead the newborn screening advisory group in terms of providing infrastructure, and have been a great resource for data and communication, as well as Kristen spent time with me traveling around the state this year giving grand rounds. And then I also want to thank and also give a shout out to Minnesota Hands and Voices. This is a parent-led, parent-run support group for children who are deaf or hard of hearing. And so if you're ever caring for kids who are deaf or hard of hearing, this is a great referral for families. They provide a great number of resources, as well as experience of other parents going through the same thing. So thank you very much. Yes, thanks, Cliff. Yeah, it varies by state. You know, I don't know if it's been broken down by, so the question Cliff asked is what happens to that other 40% of kids who do not pass newborn hearing screening and are lost to follow-up?
What's some more detail?
So I don't have a lot of detail, like as far as insurance coverage for those children, or whether certain ethnic groups are less likely to follow up than others. Minnesota's better than some other states, our numbers are getting a lot better. The Department of Health has taken on a number of initiatives to decrease the loss to follow-up rate. And for some communities in Minnesota, there's no loss to follow-up rate. Some communities, there's a high loss to follow-up rate. Some of the things that the Department of Health is doing is meet and greets, where they're going into practices and talking to primary care providers about being aware of newborn hearing screening results in all the babies that enter their practice. And what they find is after they spend some time with a practice and talk about follow-up, almost all those practices have had zero loss to follow-up rates. So any other questions?
Type 1, for instance, where there's a whole list of genes that may be positive, how do you decide in practice which ones to go after first?
Right. So the question is, when you have a condition that has multiple genes involved, particularly Usher type 1, how do you decide what gene to test first? And the answer, as you suggested, Bryce, is that you go after the thing that's most common first. So we start with Myo7A, and then we ask the laboratory to reflex to the next most common gene and go down the line. There have been some chip-based assays that we've used, particularly chips that are based on resequencing. They're not very robust for missense mutations, although for deletion duplication mutations, although they're quite robust for missense mutations. So one of the things that's happening right now is we are developing next generation sequencing tools. Many centers are doing it. We're doing it here. And so that at the same time, we'll be able to sequence about 80 different genes that are associated with hearing loss. And so I'm excited about being able to do that. We just haven't started yet. Yes?
Are there any other genes that are being considered as part of the non-syndromic causes that aren't caused by GGB2 and 6 that maybe capture some of those?
Right. So there's about 80 other genes that are in that category that cause non-syndromic recessive and dominant hearing loss that are not GGB2. Many of them are quite large and less prevalent, but nonetheless, as we look for them, we might find their prevalence is greater. So that's the hope that next generation sequencing will resolve those questions. Yeah, Harvey. Wow. I don't know, but I'm going to go read about it now that you told me. So, FICA. Yeah, I don't know. Because it's a conjugated hyperbilirubinemia, so I don't know. Yes?
One more question. And then for the kids who are identified as having hearing loss due to CMV, is their follow-up plan different, or which would expect?
Yeah, it is. So through the Lions Children's Hearing Clinic, we have a number of kids who are identified to have cytomegalovirus. One of the challenges for cytomegalovirus in Minnesota is that it's not standard of care here to look for cytomegalovirus in kids who fail newborn hearing screening. And you really need to look for CMV within the first weeks after birth, because after that, it's really hard to tell the difference between a intrauterine acquired infection versus an environmentally acquired infection or postnatal acquired infection. And so Mark Schleiss and Bazak Sharon do follow these kids, and they're treating them with ganciclovir. And it'll be really fun to have Mark and Bazak talk about their work, because it's really interesting, and it is a different management.
Do those kids respond to AIDS when they get older?
So the kids with cytomegalovirus, as far as I know, they do. All right. right. Well, thank you so much for being here.